Perfect. Anybody joins late, just let them in for me as well. Can everybody hear me and see my screen?
Yeah.
Amazing, thank you. So your case today, this lady is a Gravida 3 Para 2. She's had 2 previous SVDs in 2006 and 2008. She is a late booker at 36+4. She was a transfer from another unit, and all of her antenatal care, as far as we can tell, was all adequate and pretty much in line with what we would do at Croydon. BMI of 47 on Doltaparin. She doesn't speak any English. I can't remember which language it was specifically, but all of her antenatal care and the whole way through labour, just to clarify, we had language line to consent her for everything that we wanted to do, and everything that we were discussing with her when it came to her options. So just to sort of bear that in mind, although there was a big language barrier, we dealt with it really, really well. Co-sanguinity with her partner. 39+3, her estimated fetal weight was on the 6.4th centile, and the baby weighed 2932 grams with normal Dopplers and Lycor, but on her gap chart, it showed the baby to be under the 3rd centile. I think the reason that she was scanned at 39+3 was just due to the fact we couldn't get one beforehand when we identified the fact that she was a late booker. So that's the reason for the scan. And then obviously at 39+3, she came into triage, I believe, to have a scan reviewed, and an induction of labour was offered just due to the centile that this baby was at. So yeah, this is her baseline CTG on antenatal ward. Her criteria met at 32 minutes. This was pre any kind of induction. Baseline, probably I would say around 140 here. I wouldn't necessarily call this the most reassuring antenatal CTG, just purely because it's not got a lot of features on it that fill me with you know, it's not the one I would like to look at, but obviously it's met criteria at 32 minutes, and yeah, it was removed prior to her prostaglandin. It's taken off, and then she was given prostaglandin, and the repeat was normal as well. So there we go. She was moved to labour ward for her induction due to the centile. So this CTG, just to clarify, sorry, was at around 2 o'clock in the morning. She was basically admitted to Hope ward, and then our plan was, because of the centile and the size of the baby, we wanted to induce her on labour ward as opposed to on the antenatal ward, where the ratio of women to midwife is quite a lot higher. So yeah, she still hasn't had anything at this point. CTG again, baseline's kind of sat at around 140. Those were her bloods as well, just to sort of add that in there. The night registrar did a review at 7:30 in the morning, which was when she was sort of transferred over, and the plan was for an induction of labour with PROPES. I know that different units do this quite differently, and a lot of the time for some quite low centiled babies, we sometimes offer something like a mechanical induction instead of one with sort of a hormonal induction. But that was the decision that was made by our obstetric team from the night shift, and I believe our day shift team also agreed with that decision. So she was then put on a CTG again, and Dawes-Redman met criteria. And the plan again on the day ward round was for an induction of labour. So Dawes-Redman met at 44 minutes. And then at PROPES was inserted at 9:30 in the morning. Her Bishop score was 2, and she was found to be a fingertip dilated. IV Hartman's was started at this point. I'm not quite sure why. No sort of particular reason for it, but that's kind of what happened. Anybody have any questions?
Sorry, Cam, was she primate?
Yes. No, sorry, she's a Gravida 3 Para 2, 2 previous SVDs, I think 2006 and 2008.
Okay, yeah, thank you.
Everybody happy?
Yes.
Yep.
Yeah.
Lovely. We'll continue. So they took her off at that point. And then this is the next CTG. So we're doing them 4 hourly. I had a question from I did a CTG session with all of our new registrars when they arrived about a couple of weeks ago. And some of them sort of said that it's very unusual to see CTGs done 4 hourly on women antenatally, and they said that there's not really a lot of evidence to suggest that 4 hourly is better than 6 hourly. If anyone has got any research or anything that sort of identifies that, that would be great. I don't know what other trusts sort of do if they have more high risk women, whether they do them 4 hourly. I don't know. I think I saw some people from other trusts on the call if they do the same thing and are happy to share. But
Sarah,
yeah,
Katie, I don't think, as far as I'm aware, I think the most frequent we would ever do them normally is QDS, so 4 hour, so that would be 6 hourly, and that's for the really, 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 again, high risk, like normal Dopplers, severe RUGR. Yeah, I've never, as far as I'm aware, we've never done them 4 hourly at our trust.
thank you, Katie. That's interesting. Maybe I'll do a bit of a review on that. But this is her next CTG anyway. She's got no reports of contractions at this point in time. And yeah, baseline still remains stable. I think actually CTG looks a bit nicer with better variability in this one in comparison to what it was previously, although still not abnormal. But just gives me reassurance that this baby is cycling. So we'll continue. At 15:51, she was given dihydrocodeine, and the IV Hartmann's that we started about 4 or 5 hours ago was discontinued as it finished. Observations, as you can see, blood pressure 135/83, pulse of 92, temperature 36.6, resps of 18, and SATs of 99%. To me, this baby is showing us evidence of cycling. We've got some good variability here. We're possibly going through that sort of deep sleep cycle for this baby. And then towards the last sort of 4 or 5 minutes, it looks like it's about to pick up a little bit again as well. Despite the fact that there's sort of no record of contractions and it didn't appear to be feeling like she was having any contractions, she was given some dihydrocodeine because she was in a bit of discomfort at this point. So CTG was removed as it was found to be normal. And then this is what we see at 19:22. So this is sort of 4 hours, again, 4 hours later, we're doing 4 hourly CTGs for this woman. Anybody notice a difference?
There's a baseline rise.
Yeah.
The deceleration right in the middle.
Yeah. What do you want to do about it?
Remove propase.
Yeah, could do. Anything you want to do beforehand, or are we immediately removing the purpose?
Position change.
Yeah, can do. Absolutely.
Check maternal obs.
Yeah, absolutely. Just to double check, make sure we're picking up everything that's still normal. What tends to happen when you get a baseline rise on a neonate on a CTG? What can that be an indication of?
For you?
Yeah, it could
You
be
are
an Pardon?
Yeah,
I didn't hear that. Sorry.
Tara, was this lady a BMI of 47? Is that what you mentioned before?
Yeah, 48.
48. So this lady is high BMI. We can't, she's in discomfort and paratooth, requesting dihydrocodeine. So she could be actually like contracting, and we can't really palpate it or get it on the turco because of the high BMI. So to be fairly honest, I would examine her first to establish and palpate the abdomen really well to see, is she contracting, trying to see if actually we are getting abdominal contractions, and VE her to see, you know, she could have progressed very quickly as well, considering that she's para too.
Yeah, absolutely. Totally agree with you there, Maya. I mean, in terms of baseline rise, there's two things that generally stick out when you do see a baseline rise. One is infection, one is evolving hypoxia. We've got presence of a deceleration there, which in my brain makes me think, okay, if we're thinking along the sort of choreo route, we normally don't necessarily have to see decelerations prior to a baseline increase. Normally that happens first. Sepsis wise, we would obviously see maternal observations that would become, mum would become tachycardic before we see it in the fetus. And then if we've ruled those ones out, then it tends to be hypoxia related. So yeah, absolutely. If she's made very quick progress, that's definitely a factor that we'd want to consider. And also, you know, BMI of 48, how realistic is it going to be that our TOCO is going to be working very effectively? And I am to believe that this woman did carry the majority of her weight in her abdomen as well. BMI is obviously a thing where we rely quite a lot upon it, whereas actually there's not a lot of sort of circumstantial evidence behind it. However, obviously, if we do have quite a lot of adipose tissue in the abdomen, then that can seriously affect the way that we're monitoring a baby. The good thing is we've got good contact with this fetus, but what I would expect if we weren't picking things up like this on the TOCO is that we would be doing exactly like Maya said, our abdominal palpation, making sure if we can feel it, we're palpating for resting tone and seeing if these contractions are quite frequent. So we'll continue. At this point, nothing's really sort of done about it. And this is the CTG that we've got now. The question in my mind is, okay, have we got a baseline of 140 and are these accelerations, or have we got a baseline of 155 and these are chemoreceptor decelerations? And how are we recording whether or not these are more chemo related if we've not got any contractions being picked up on the CTG? I know that quite a lot of midwives, when we have a situation like this, for example, whereby we're not picking up contractions on the TOCO on the screen, midwives tend to write like little C's or little things on the CTG trace itself to sort of show where the contractions have been happening. But I have checked the paper version of this, and there aren't any. So just again, this is something I say on a weekly basis. We need to be making sure we're doing our best to try that. And also, if you're unable to palpate them, ask for advice, ask for support from maybe somebody else. But we need to be documenting that very clearly. So the night team come on and there's a consultant ward round. There's no CTG concerns at this point as it's defined as a gradually evolving hypoxia that's compensated, and the patient is reporting painful contractions every 2 to 3 minutes. We haven't done any kind of VE or any assessment. What do we think plan-wise?
A vaginal examination.
Yeah, absolutely. I definitely agree. Okay, so we
And
still
also again to palpate the contractions as well.
Again, yeah, absolutely. I know you those of you that come to these frequently hear me waffle on about this continuously. But yeah, really, really, really important. And if we can also be encouraging our peers to do this as well, then that would be fantastic whenever you're doing a fresh eyes assessment or anything like that. Making sure that we're encouraging each other to do this as well. So blood pressure is 137/60, pulse is 88, resps of 18, and a temperature of 36.6. So kind of ruling out a little bit there that mum's infected, sorry. And then at 21:08, the anaesthetist comes in as this client is requesting an epidural. And then they discuss doing an epidural sighting with the woman in left lateral because it would be difficult to monitor the baby as well as her if she was in an upright position. Still no palpation of contractions. And we are now, these are sort of chemoreceptor decelerations, aren't they?
Ara, I'm just wondering, I know the contact here is good, but or maybe I missed something. Was there ever thought of an FSC put on before now?
We don't, I mean, we do use FSCs, but we don't use them very frequently, Katie, just purely because it's not something that we ever need to use. So we don't have Stan, for example.
Yeah, no, of course.
But if the contact was bad, then that's the first thing that we would go around and recommend.
Yeah.
But because we're picking up this baby so well, there's not really an indication for us to offer one.
No, that's very fair. Good point.
And she's induction as well, so we're still 1 centimeter from the last VE, so we don't even know how many centimeters dilated she is. The prop is still in.
Yeah, absolutely.
Yeah, so we can't in this particular case put an FSC right now. Obviously, it's quite recommended, I think, that we do examine her, because also what we are forgetting that this lady is induced for a presumed diagnosis of placental insufficiency. So the baby is on the 3rd centile. So we do know already before starting the induction that this placenta hasn't got good reserve. So we could also be dealing with hyperstimulation. Hyperstimulation does not necessarily mean that you're having 5 to 7 to 8 contractions in 10 minutes. Sometimes, if with a background of placental insufficiency, 2 to 3 good contractions could be enough to send this baby straight, to kind of like shift the tilt, the balance, to releasing the catecholamines or decompensating. So I think examining in this particular case is quite advisable, just to see exactly where we're progressing and kind of know exactly where we are in labor wise and induction, sorry.
Thank you, Maya. Yeah, absolutely. Okay, we continue. I don't know about you, but I would imagine that we possibly had forgotten at this point that the PROPES was still in situ. So at 21:27, the night reg and consultant come and do a review, and this is when they recommend an examination. The PROPES is removed at 21:31. She's still multips os, and she is the baby's head is still high. I think it was -3 still. And the plan was to keep her nil by mouth and essentially continue monitoring to see what happened and see if the CTG would resolve following the removal of sort of the induction method. They then tried for 20 minutes to try and get the fetal heart rate. But due to mum's position changes and possibly a change in fetal position, it then became virtually impossible to pick up this fetal heart rate. So bedside ultrasound was used, as literally couldn't find the fetal heart rate at all, despite them moving into multiple different positions. At this point, this is when we would definitely recommend an FSC, but she's multips os. We're unable to do that without significant risk of, attaching it to the wrong place. And also, she's still fingertip dilated. So
she also
accurately
hasn't shrum yet either, has she?
Yeah, she also hasn't shrum yet. So an ARM, we definitely wouldn't ARM this lady, considering we've got an abnormal antenatal CTG. We've also got no fetal heart rate contact. So we don't know whether this baby is even remotely well before we then start a process of almost like another induction method. We've just removed a PROPES to see if that improves the CTG trace, to see if that helps the baby to sort of recover from these decelerations that have, been gradually evolving to become worse and more frequent. We're not going to ARM her because we know that that can increase the frequency of contractions, but also can possibly end up causing distress to this fetus. And we haven't got a fetal heart rate. So multiple different factors here make this very, very, very complicated. So what do we do? You can't put on an FSC. because
Did they
her,
find
give
the
her
effect
Vitaline.
with the scanner?
pardon.
Did they find the
did
effect
they?
with the scanner?
Yeah, they did. But then even when they were moving the CTG around to where the fetal heart rate was on the woman's abdomen, still couldn't get it for this segment anyway.
I know I'm jumping the gun. Cesarean.
You
But
can't
it's
do
a very, very tricky thing for cesarean. Remember, this lady is a BMI
Oh, she's
48.
increased BMI.
Exactly.
yeah.
So, and she's a previous two. So whoever's going to make that decision, this is a very, very important call. Number one, it's night. So it's the night team. Yeah. Number two, she's a very high BMI and para two. And we're inducing her because baby's small. So there's, at the moment, to make that decision at nighttime, it's really actually very tricky one. So to be fairly honest, from my point of view, I would give her terbutaline and rest her to see if I can monitor the baby, focus on monitoring the baby, and then we can start planning the induction again. Once you stabilize this baby at this stage and make sure the baby's settled from the induction process, I think we can plan it less like not during the night if the baby comes back to the baseline and gives us more reassuring signs. I think that now we need to focus on just establishing how to monitor the baby.
Yeah, absolutely. It also put yourself in the shoes of this team right now. We can't do an ARM. Well, sorry, we can't put an FSE on because it's unsafe to do so. And we can pick the baby's fetal heart rate up in an ultrasound scan, but we can't get it on monitoring. And we've had for the last, 40 minutes at least, it's been quite an abnormal CTG, and she's still multipsos contracting and in pain. So and it just when we're thinking
it's a
about the
bit of a
human
tricky
factors of
one
this,
here.
yeah, think about the human factors in this situation as well. This must have been quite a stressful situation for the midwives and for the entire team actually that were involved in it. So she started vomiting, plus. I'm not sure how much exactly as it wasn't recorded. Loss of contact was reported due to reduced fetal movements or lots of fetal movements. I'm not quite sure. And she went out to the toilet at this point as well. Personally, for me, and I think some on here will agree, if we are in a situation whereby we haven't had good fetal heart rate monitoring for a period of nearly 30 minutes, we've had previous abnormal antenatal CTG with decelerations, and we're unable to pick up the fetal heart rate on a monitor or do anything about the fact that we can't pick up a fetal heart rate on a monitor other than hold a scanner to her abdomen until we do manage to get it on a CTG. I wouldn't necessarily be recommending this woman gets up out of bed and spends a prolonged period of time in the toilet when we don't know how well this baby is. At 22:08, they did manage to pick up the fetal heart rate. There's lots of little fragments, as you can see here, where I think the baby we were picking up for seconds at a time. But there was query whether or not it was maternal pulse or a deceleration. As you can then see, we then pick the baby up perfectly clearly again. And this is the trace that we walk into. So Maya, they did exactly what you would do. They gave terbutaline to try and rest the baby. We're still not picking up any contractions either. Midwife in charge is in the room. Terbutaline is given in this case. Do we think this is going to help?
It's our best hope at this stage, to be honest.
Yeah, absolutely.
Yeah.
So for me, Cara, I agree with my terbutaline, but with the intention to move to theater.
Yeah.
I wouldn't give terbutaline and stay in the room. Like, yes, she's high BMI, but we have the Alexis retractor, we have the other things, and with a baby who is third centile, we are risking that we have an HIE on this baby. So yes, terbutaline, and make plans if she is still close cervix or 1 centimeter or whatever. We are not going anywhere. Move to theater.
Yeah, absolutely. So it normalizes. At 22, she's given her pre-medications because they are anticipating that if the contractions pick up again, that, you know, the decelerations may come back and maybe as poor of a CTG as it was previously. Think something I just want to really push it. She's she's fingertip dilated. We shouldn't be seeing signs of distress like that in a fetus for a lady that's not even in active labour yet, despite the fact that she is obviously contracting. Well, reasonably regularly, considering she's been discussing having a spinal, an epidural. She's given paracetamol and dihydrocodeine at this point. I believe the reason why she was given this, and this is something that I think we do often do, we don't withhold anaesthetic from an anaesthetist, but if we're anticipating going to theatre, the preference tends to be to perform a spinal as opposed to then put an epidural in, which we know can take 20 minutes to put in and 20 minutes to work, and then topping that up again quite quickly afterwards. So the plan was, let's see if the terbutaline has an effect for a longer lasting time and then go from there, essentially. And the registrar plan at this time was that they will monitor it for a period of time, keep her nil by mouth. But if the CTG remained stable as it did in the first sort of 10 minutes after terbutaline, that we can rest her and rest the baby overnight and then possibly start the induction process again in the morning. We all know as well that terbutaline can increase baseline because it does have that effect. We've already had a baseline that's been increased previously, so that's something that we're going to expect and also be very much aware of. So we're not going to want to stress this fetus out any further. And if the contractions did come back, then yeah, like Mr. Naguib said, you know, move to theatre. We know, obviously, risk factor wise, BMI of 48, she's at high risk of postpartum hemorrhage. Terbutaline, although people always say that terbutaline increases your risk of postpartum hemorrhage, the research suggests that actually the difference between an EBL of a woman who hasn't had terbutaline and a woman that has had terbutaline in a similar circumstance is about 150 mils. So if this woman didn't have terbutaline and we took her to theatre and she lost 500, if we gave her terbutaline, the likelihood is she'd lose 650. For reference, anyway. So we continue. Baby's baseline is now 155 and it's always previously been sat at 140 when it's been normal. At 23:04, the registrar was called back into the room. Registrar was present, consented for an epidural at 23:15. We're still having sort of chemoreceptor decelerations. And although it's very faint, you can somewhat see the contractions that she's having a bit more clearly on this CTG, where you're seeing those very small lumps. And what you might also notice is that these are late. So these are chemoreceptor decelerations. They're starting at the peak of the contraction and recovering well after it's finished, if we're going by that. I would obviously like the TOCO to be a lot clearer, but this is what we're working with, and we don't use those intrauterine pressure balloon things. I don't know if we've ever used those at Croydon, and they've never been there since I've been there, but I know some trusts across the UK do use them to monitor contractions. But they would probably have benefited us in this situation. Mr. Naguib, have we ever used them?
Which one?
You know, you can get those. I think they're more used in America than they are in the UK, but they're like an intrauterine. They look like an inflated catheter, and then they go into the vagina, and they basically monitor for contractions better than a TOCO would. So it's a device that stays on the inside.
The one that I know doesn't go into the vagina. I don't know, but I haven't seen it used, and it is intrauterine. It is something that is inserted through the cervix to feel the intrauterine pressure. But
That's
I'm
what I
not
mean.
aware.
Sorry, I I didn't mean put into the vagina. I meant that.
But I am not aware of, or let me put it in a different way. I have not seen it used in any of my previous unit or currently in any, like anybody told me that they use it. I am not aware of that. Maybe somebody can tell me differently.
I agree, Cara. I've not seen it used
Not seen it.
in any, not in 8 different hospitals. So no.
Oh, interesting. I don't know whether they're used. Maybe I'm wrong in saying that they're used in the UK. I know that they're used in America. But I could be completely talking out of my behind if I'm saying that they're used in the UK and I'm just thinking of something I've read that's actually American as opposed to English.
And also similar to the FSC, if you want to use something like that, and she is fingertip or whatever, how can you put it in? So you need to also like put it inside the cervix. So still is not feasible.
Mm. Perfect. So, Reg is now present, offering a cesarean section, but the client was declining. A second terbutaline was given. The rationale from the midwife in charge for the second terbutaline was that we were unsure of the baby's condition due to loss of contact. And then, as you can see, we've possibly got maternal pulse here. Note that I haven't put any observations on this set of slides because we haven't really been recording them very frequently. 2350, the registrar was actually present whilst the woman was lying down for her epidural because we couldn't get fetal monitoring whatsoever whilst the epidural was being sited, and we were just purely picking up maternal pulse. At this point, would anybody have liked to have done anything differently?
I just really feel for the team who were on that night. That just looks, I just feel stressed looking at this.
Yeah. Yeah, me too. It's very easy for us. Again, we use hindsight. We say the words hindsight is a wonderful thing on a daily basis, probably. But I really did think of what was going through the minds of the team that were on this night shift, because specifically as well, if you're recommending something and a patient's declining it, there's nothing that we can do about it. The only thing we can do is try and make sure that we're in the safest position we possibly can. And we're not gonna
Yeah.
go on, Katie.
I was only was going to say was if you're not picking up the FH at all during the siting of the epidural, then it needs to be, the epidural site needs to be abandoned until you can confidently feel that you've got a fetal heart rate recording, because epidurals obviously can decrease maternal blood pressure quite quickly and then cause problems. So as hard as it is, and I know she's wanting pain relief, if you're not happy, you're not listening to your baby, that needs to be rectified first.
Yeah, 100%. 100%. This was something that we had as a very common theme sort of earlier on in the year, but I'm very pleased to note that we've made such massive progress in fetal monitoring whilst an epidural was being sited. I don't know if you have the same situation, Katie, at Epsom and St Helier, but quite a lot of the time the midwives are required to sort of support the anaesthetist in some kind of way whilst they're siting the epidural. It can be something as simple as, holding the vial whilst they draw up medication, or cutting out the sticky pads that go on the patient's back once the epidural is in. But that does obviously take away from the fact that we are supposed to be measuring the fetal heart rate. And something that I've put across multiple times is the fact that your priority as a midwife in this situation is to try and get fetal monitoring. Now, I know in this case, and it's very heavily documented, that they were trying very hard to the point where the registrar is in making sure that we're getting maternal pulse on a monitor as opposed to fetal pulse. whilst this is being cited. So there's a lot of people in this room that are there supporting and trying to get this fetal heart rate, but this patient is obviously asking for an epidural. And yeah, the situation was essentially to try and get one on board as quickly as possible, which is going to be even more difficult just due to the fact that her BMI is like 46. This is what we see after. Sorry, Mr. Naguib, do you want?
Yeah, what I would have liked, like in the documentation, maybe is rather than the word offered, I would have put recommended. Number one. Number two, I would have loved to see recommended C-section with the possible so and so and so and so and so and so to the baby.
Yeah.
We were quite heavily criticized by HSIB in one of the cases 7 years ago or so about that we offered induction to a lady, and we wrote offered in a baby who was on the second centile and all the usual, and she declined. And then she was a BMI of 55, and she came in labor 3 centimeter with a flat trace and had a cut one section, and the baby is HIE. So when we were talking to the HSIB and we said that we offered, the comment from HSIB was very simple. When you offered, you as a consultant and you as a registrar, have you mentioned clearly that this is your recommendation and the drawbacks of not having it is stillbirth? So we said no. We said that we were going round and round without mentioning the word stillbirth, because I still, even till now, feel very cautious and very, I don't know, very apprehensive about mentioning to any woman who is pregnant, your baby is going to die so blatantly. But this is how it came from the lawyers, that we don't use the words as they are, so the patient can easily deny that we mentioned that the baby can die. So I don't know yet how to formulate such words in labor, but at the same time, I would have loved to say our recommendation is a C-section, not offered. We
Yeah.
recommend a C-section with the risk of so and so and so and so.
Thank you, Mr. Naguib. Loading dose was given just as we managed to maintain, get back fetal contact, which was an ideal situation so that we could monitor for any sort of acute hypoxia that could have happened. And this is, it sort of continues as is, really. At 0045, the registrar comes in and does a VE and finds this lady to be multips os with no change from her previous examination. I would argue that this looks to me, this gives, if I was on labour ward right now and this is what I saw, I'm still getting no contractions on the TOCO, but I would say that this looks very suspicious of a possible subacute hypoxia, or about to become, if not bordering on, a subacute hypoxia. And we know that babies that are hypoxic, specifically subacute hypoxia, their pH tends to drop 0.01 every 2 to 3 minutes. So at this point, I've given 2 terbutaline. We've got absolutely no progress from her initial start of induction. We've done our best to try and stop this baby from becoming increasingly hypoxic. And the baby just does not enjoy and does not want this labour to continue, in my opinion. At 0005, this woman was consented for a category 2 cesarean section, and the consultant was called in for support for the registrar due to her BMI and the possible need for support. So we went to theatre, and this is what happened. At 01:17, she had a spinal top-up. At 01:32, a 2222 went out, which is our emergency phone. Knife to skin at 35 past, knife to uterus at 38 past, and delivery within 1 minute. The consultant was, I don't think the consultant was present at all. I don't think they haven't had the chance to come in yet at this point, or they were definitely on their way. And this is what we've seen. So we've gone from a possible subacute to somewhat of a not subacute. And then I think the spinal probably tipped this baby slightly over the edge. And what concerns me about this prolonged deceleration in particular is the fact that we've got very reduced variability within it. And because we've had a previous abnormal antenatal CTG, we're very unlikely to have seen this have recovered, although we know we're going for delivery. Just as a sort of side note, if we've had an abnormal trace before, a prolonged deceleration, and we've got reduced variability within the first 3 minutes of a prolonged deceleration, this is sort of indicative, like, with this baby needs to be delivered. So what do we think our outcome is here? Anybody want to have a guess?
7.0, 7.1.
Okay.
Yeah, I was going to maybe say the same, given that they went to delivery so quickly when that final acute incident happened. Probably baby needed quite a bit of stimulation, maybe inflation breaths.
Okay. Anybody else want to have a guess? Beth?
Yeah, same as what everyone else has said.
Cool.
Maybe even ventilation breaths.
Perfect. You were spot on. This baby had APGARs of 1, 9, and 10. These gases are the same, unfortunately. Arterial pH of 7.05, base excess of 10.5, and a lactate of 11.1. No delayed cord clamping, sadly, just due to the condition of the baby when baby was born. Had 3 sets of inflation breaths followed by ventilation breaths, and then had an oxygen requirement. So this baby was admitted to our neonatal unit, where it was screened and treated for sepsis, but then was brought back, thankfully, to our transitional care when the oxygen requirement had been weaned off. This baby was on the 1.1 centile. So it does, when we put it all together at the overall clinical picture, it does make a lot of sense. 2,705 grams, not a bad weight, but obviously we use our customized growth charts. I'm not sure what this baby would have been on the WHO growth chart, because I know we're sort of we're possibly transferring our post-birth weights over to this. But yeah, this baby was hypoxic and had been hypoxic for a sort of prolonged period of time. Our lactate's very raised. Our base excess is also raised, and our pH is low. I'm not sure. I would say that this was more likely to be arterial as a gas as opposed to venous, but they're definitely not two different things, as there's only a difference of 0.01. But yeah, the baby's made a full recovery and is absolutely fit and well and happy, and was discharged, I think, 48 hours afterwards, which is a really good result. But yeah, very stressful situation, I think, for the team that were involved in this case. But yeah, glad we ended up with a very positive outcome in the end.
And a very good decision for the section as well, because, as I said, very early on we knew this baby wasn't fit for labour.
Yeah, absolutely, absolutely. And I think as well, you know, obviously we consider what mum didn't want a cesarean section. At the end of the day, her wishes were respected until it got to a point where we thought, actually, no, this is seriously recommended now, not just a suggestion. Although I'm sure it wasn't actually like that, although that's the way it's documented.
To be honest, Cara, I think it was a very tough case for whoever was on call during the
Oh,
night.
absolutely.
And you mentioned at the beginning that she doesn't speak English, so there was the English barrier as well.
Yeah,
So everything was taking extra time, and
yeah,
obviously the monitoring was a big issue.
yeah,
I think this is like definitely a placental insufficiency case, and I think if the lady was not multi, it would have worked better towards the benefit of the registrar on the night. I think
yeah,
she was contracting quite a lot more than what the baby could tolerate. And the fact that she was multi, she was kind of progressing, yet not enough to kick labor to start. If she was a nulliparous, obviously it would have taken much longer time, and maybe that night shift would have been better. But I think you raised a very important point at the beginning of the presentation regarding mechanical induction. And I think if we're suspecting a placental insufficiency to start with, maybe we should start considering balloon induction or dial-a-pan or something like that. We might have managed, not that we would have achieved a vaginal birth, but maybe in high BMI it would have been easier to manage.
yeah,
And at least you would have dilated the cervix enough to be able to put an FSC later on when you are not really monitoring. Maybe ARMing her at that point would have really made things worse. So there's always the possibility of how things can go. Would it go this way? Would it go that way? So it was a very tricky case, and I think it's a very good one. So thank you.
Thank you, Maya. Yeah, no, I totally agree. Maybe it's something that we need to discuss as part of our guidelines and what we would recommend and what the threshold is as well for mechanical induction versus hormonal or chemical, whatever.
Yeah, I think many units. I know Kingston, for example, they are very easy with using mechanical induction. They actually prefer it. But definitely, I do recall when I worked there a couple of years ago, for any IUGR or small for gestational age, it was a mechanical induction, not a PROPES.
Yeah.
So I think putting a PROPES in IUGR induction it has to be like a consultant decision. But you mentioned initially it wasn't it?
Yeah.
So maybe it's something also to look into. Maybe we can change that in the unit as well. I don't know what Mr. Naguib thinks.
You are right, Maya. I when I worked in George's, though, we had, and this is again from, as I call him, my guru and my teacher for CTG is Austin. Um, he would use Propus for every single person on earth, even VBACs. And the protocol there was, but this is 2013, so I don't know maybe if they changed it or not. But uh, they don't use one cycle of Propus; they use two cycles of Propus back to back. So 24 hours of Propus, then 24 hours of Propus, even in VBACs. And I was quite like distressed when I started there with the kind of like gallant way of going with Propus. And especially that on my presence there, luckily it's not my shift. They had two rupture uteruses with bad HIE, but the guidance did not change. On the other hand, having used Dilapan in Croydon for now 2 years or 3 years, and then we stopped it. We stopped it for one reason, and we are not pointing fingers here, but whoever the operator was putting the Dilapan in was putting it in the vagina. And in such a lady who had a cervix which is possibly um, multiples, as we say, which can accommodate 2 or 3 rods, I see even in Primeps 5 rods inserted, and I kept talking to the people putting it that I sometimes struggle to put the 3.5 millimeter hysteroscope in the cervix. How come you are putting 3 or 4 or 5 dilapans in this exact same cervix? And the answer was no, it is in, and so on. So the operator was one of our failures of stopping the dilapan in Croydon, because when we audited it, we found that the audit found that our success rate with dilapan was very poor. And I thought of saying, okay, let's take it in our hands. We have 2 or 3 midwives who insert it. We have 2 or 3 registrars. We have 2 or 3 consultants. It didn't work either, because these 2 or 3 that I mentioned are not working all the shifts. And as if I'm giving preferential treatment to some ladies. So in this specific woman, I agree with you, Maya. It could be a balloon induction and a balloon inserted in labor ward, and uh, yes, causing some dilatation, and then we might have been able to ARM her. Similar to what you said, whether the ARM would have caused the same stress, I don't know, and we would never know. Maybe this uterus would have been very difficult to contract and reach a full dilatation, and the head was not really engaged, and not pressing on the cervix when we are doing all of this. So yes, but it is subject to decision making, as you said, right decision making, right choice for the right woman, and it is never the same, like a blanket. And I wouldn't be more inclined, like Kingston, to have it as a blanket to do all the IUGRs with a balloon. And I wouldn't be inclined to be like George's, where we put propus for everything. I think, again, we come to the same outcome as we say all the time. If we are playing nicely ping pong with this baby and chess, we are knowing his or her next move, and we plan this ahead of time. And exactly as you said, and Kara said, we knew that this baby is going to be distressed sometime. Then we give terbutaline, then we wait, then we do this. We know the outcome. We knew the outcome, all of us, 4 hours ago from the start. And we knew that we are going to end in the same story, but we wanted to delay it because, as you rightly said, we are on the night, we are BMI previous to, and how the lady is acting. But again, it is anticipating the next move and knowing what is the next move of the baby is important. And as you said, a balloon would have worked, but we don't know. Yes.
Thank you, Mr. Naguib. I think it's also really important to notice, like with Dilapan, the research and the sort of results from the trials that they did with Dilapan were actually really good, but only when an ARM was performed within the first like 2 hours after they'd been removed. And I think half of our problem with Dilapan was not only were we possibly putting them in the wrong place, but also we didn't have the sort of capacity to move them to labour ward for an ARM with such a short time frame between them being taken out and then further induction being started, which didn't help
Exactly.
matters.
Exactly. And we were fixated on the 24 hours mark when the Dilapan people specifically and categorically said 14 hours is the best time.
Yeah, for sure.
14 to 16, I mean 14
And you
to
can never
16 hours.
time that
Yeah.
when
Yeah.
you can never time that with midwives' availability on labour ward.
Exactly. You want to get them to labor ward, and then an emergency comes, and we treat them like propus. Oh, let it be inside, or you remove the propus. So it is not the same. So you need a complete set, completely different set, where you have availability, where you have prompt action on the 14th to 16th hour.
Absolutely. Perfect. Well, thank you so much for everybody's contributions tonight. I hope you enjoyed the case.
Yes, we did.
Thank you.
We did.
I've
Thank you
got
so much, Cara.
I've got a cracker for you next week. So would love to hear all of your opinions this time next week. So yeah, thank you everybody.
Thank you.
Thank you, Cara, so much.
Good night, everyone. Bye.
Night.
Good night.
Bye.
Bye.